Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by sMater, an Australian leader in healthcare for more than a century. I'm your host, Gillian Whiting, and we're coming to you from Meanjin, the land on which this podcast is being recorded.
And I'm Dr Maria Bolton, GP specialist and former president of AMA Queensland.
Today we are joined by Dr Harsheet Sethi, hepatobiliary surgeon at sMater.
We are sMater.
We are sMater.
We are sMater.
This is sMater.
Harsheet, welcome to sMater.
Thank you. Pleasure to be here.
We're talking today about gallbladder diseases. I think we should start firstly with what diseases are we talking about and how common are they in Australia?
Okay. Well, the commonest referral that comes through to me is for gallstones or pain in the upper abdomen. And these patients can present for a period of time with the vague right-sided abdominal pain, sometimes radiates to the back and the shoulder. They go through a series of investigations before they come to the conclusion that they do have gallbladder disease. Now, gallstones being the commonest, it probably affects about 15 to 20% of the population. Historically, we've always said it's in fertile females of 40. That's actually changing, and we can go into that a little bit more. We're seeing younger and younger patients, more males, and certain weight loss medications and surgeries have increased the incidence as well. But other than gallstones, which most of our GP colleagues are very well versed with and have managed for years, we do see a lot of incidental findings on imaging done for, say, a road accident or a different problem altogether. And it leaves a big hole in the system where people don't know what to do with this. There's a terminology for this now called vomit, and the patients are victims of modern imaging and technology. And I'd love to take the chance to sort of disband and look deeper into some of these myths and some of the investigations and stop ourselves from going down that rabbit hole.
I am so glad that you're in a myth-busting mood, and GPs referred to some of these findings as incidentalomas. But can we dive into gallstones and perhaps into what the risk factors are for gallstones?
Of course. Now, gallstones are two slightly different types depending on ethnicity and where you live and your diet, perhaps. In Southeast Asia, we do see a fair predominance of pigment stones, whereas most of the Western countries, and certainly in Australia, they're dominantly cholesterol stones or mixed stones. So they do depend a lot on our diet and the cholesterol being high in our bloodstream. Now, there's often a combination of gallbladder dyskinesia, which means the gallbladder is not emptying properly, to predispose people with high cholesterol in their bloodstream to precipitate stones and form these gallstones in the first place. So we still deal with ethnic different diversities and ethnic populations in Australia. So it's not to say that we can't have pigment stones, but the commonest stones we see are cholesterol or mixed stones. They're primarily formed in the gallbladder, but they can get complications where they slip into the bile duct and present with jaundice or pancreatitis.
And it's not just women. You said that's it.
No.
Historically, that has been
historically,
thought to be the case?
We think about it more in women, and we do see them play up during pregnancy or just postpartum, but we do know that's probably the fluctuation in weight rather than the pregnancy hormones that precipitates some of the gallstones and biliary colic or the pain associated with gallstones.
Is it possible to compare what you're seeing in Queensland to global trends as well?
So I think gallstones in Queensland would not be exceptionally different to compare to the rest of the world. We are seeing it. I think what's different is it's not just, it does run in families. So we do see it even in younger, fitter women who don't expect to find it. And they're looking for a genetic link. I haven't been able to establish a genetic link per se. So perhaps it is diet and lifestyle because families make similar choices.
Sometimes we have patients who listen to these podcasts. I know this is a question that GPs know the answer to, but what are the most common presentations when people have gallstones?
So the commonest complaints would be pain in the middle of the tummy, just under the breastbone or the epigastric area, and it often radiates as a banding pain across the upper abdomen and down to the back or to the shoulder blades. It's often triggered by fatty foods. Like I tell my patients, there's no food there's no meal, however good you're being, that has no fat in it. So it could be anything. And people don't often think about the good fats when they're thinking about whether they had a fatty meal. So they're really surprised that the avocado triggered their pain attack, or a piece of salmon or tuna, because they thought they were being really good. So they don't really think about the good fats. It also then presents with nausea and vomiting. It pretty much has a mind of its own, so it does usually resolve within the half an hour to in 1 hour. But people will always tell me that they couldn't do anything to get comfortable during that episode of pain, and certainly ladies have told me it was worse than labour pain. So it is real and it's bad. Saying that, some people do get a milder version of more of a lingering pain. I have had patients present just with nausea, and that's why they need more investigations to establish the cause being biliary colic.
And so that means obviously some imaging, and then what findings then, and what are you looking for at that point?
So the commonest imaging for gallstones would be an ultrasound abdomen. It's just a usual jelly scan. That's most people are comfortable. It's non-invasive. It is a little bit dependent on who's performing the scan, whether the patient's adequately fasted. But we do get gallstones seen very well on the ultrasound. They also comment about the liver and whether there's fatty liver at the same time, and they will comment about the size of the biliary ducts, both within the liver and outside the liver at the time.
Can you help us interpret incidentalomas and also, talk about vomit? I was wondering especially about polyps, but the other finding we also see is a porcelain gallbladder.
So porcelain gallbladder has gone through phases of getting all of us very worried about its potential, malignant potential. And we did sort of talk about 1% chance of porcelain gallbladders being cancers, or even higher. There was 10% at one stage, but it's been downgraded to just the 1% now. And in my experience, most of the porcelain gallbladders are actually just large calcified stones, which perhaps have a calcified rim rather than a true porcelain gallbladder. We'd still recommend laparoscopic cholecystectomy for a porcelain gallbladder, because also anecdotally we know that radio-opaque stones and large stones will cause symptoms at some stage. So even if they're relatively asymptomatic at this stage, they are going to cause complications such as chronic cholecystitis or fistulization of the stone into the bile duct perhaps, or myrices. And these stones, if they're large, should be removed, and a porcelain gallbladder should be removed laparoscopic as well, but the malignant potential has been downgraded to about 1%.
And did you want to maybe expand on polyps? When should we worry? Is there perhaps a number of polyps, or what they look like, the size?
Yeah, it is something that I am very interested in, because I think there is no real surgical consensus around it either, and even if you look through the guidelines. So I did look at this because as a hepatobiliary surgeon, we were relying heavily on just consensus and sending out surveys to surgeons to see what they did, because there wasn't a unifying guideline for the longest time. And I noticed recently that some of our radiology reports are coming out with what to do with guidelines on polyps. So there has been a change in the last couple of years. So it did prompt me to go and look up what's changed and what the guidelines are. And the only Australian guidelines I could find were the RSEGP ones, which are still very relevant, but there has been a couple more guidelines that have superseded that in the surgical sphere. So in general, the RSEGP, or our historical practice, has heavily relied on the size of polyps, and we've tend to not worry too much about the under 5 millimetres and offered surgery to the one approaching the 1 centimetre mark. But I think it's interesting to actually think about the morphology of the polyps and what is polyps and how many of them are true adenomatous polyps. A large proportion of the polyps referred to us are actually pseudopolyps, so they could be inflammatory polyps, in which case patients could be presenting with symptoms of biliary colic but not find stones and just have these small inflammatory polyps. Or the commonest by far is cholesterol polyps. In general, we find that the pseudopolyps tend to be small and multiple. So in as much as people worry about having multiple polyps, that's actually reassuring, because if you've got multiple polyps, it's likely to be a pseudopolyp. It is the single large polyp that I'd worry about more. The ultrasounds are also now categorising polyps, a bit like colon cancers, into sessile and pedunculated. So the pedunculated polyps, again, are lower risk. So we do have European consensus guidelines that came through, mostly driven by radiologists, but there were some surgeons present in that conference. It was an ultrasound consensus conference. And they did start defining, and I'm really pleased to see that Queensland X-ray at least and some of the other radiology groups around are reporting and putting a little cheat sheet, so to speak, at the end of their ultrasound reports talking about sessile polyps and pedunculated polyps and what age, what size of the polyp you worry about. But what also needs to be kept in mind as a GP seeing the patient is their ethnicity. So it's much more likely to have a transformation into gallbladder cancers or be a true polyp in the Southeast Asian population and South American, and particularly Chilean. And these are the places which have the highest incidence of gallstones and gallbladder cancers. It's also important to keep in mind whether there's a family history of gallbladder cancers or whether the patient themselves have had investigations about cholangiocarcinomas. And the last thing to keep in mind is whether they've got inflammatory bowel disease, in particular PSC, because they tend to have a higher risk of a cholangiocarcinoma. So the European guidelines have recategorised polyps into the very low risk, and the high risk. And in the very low risk, actually, they've increased with this single pedunculated polyp. If it's got vascularity, which you can tell on the ultrasound, you can actually leave them up to the 15 millimetre mark without considering surgery and without worrying too much about malignant transformation, because it's only 0.5% chance of even the big polyps becoming cancers. Whereas the sessile polyps, more than 7 millimetres, especially with the ethnic background of Southeast Asian and Indians, should be referred for surgery.
You've mentioned ethnicity and family history, but what about red flags for gallbladder cancer in asymptomatic patients? Is there anything else?
So most gallbladder cancers will have gallstones, whereas the corollary is not true. So we used to, generally in the global population, we sort of quote that 1% chance of getting a gallbladder cancer if you've got gallstones. My experience in Australia has been that it's actually lower here, and I suspect it's probably because we're dealing with gallstones more expeditiously. We're not leaving people, because it is a chronic inflammation that predisposes them to gallbladder cancer as well. So perhaps timely intervention for gallstones is playing a part, but it's also, like we said, they're not ethnically predisposed to getting gallbladder cancers. So in general, gallbladder cancers are difficult to diagnose. Cholangiocarcinomas are particularly difficult to diagnose. They can go undiagnosed with just a little bit of loss of appetite, some weight loss, perhaps a vague right upper quadrant pain, and some people can just present with jaundice and cachexia and weight loss at the end. So these are actually quite difficult to diagnose, and it's not something we would be looking for, because the risk of gallbladder cancer in Australia is not very much. It's 3 to 4 per 100,000.
According to the GloboCan 2022 database, there were more than 122,000 new cases of gallbladder cancer and 89,000 related deaths identified worldwide in 2022, with Asia accounting for approximately 70% of both cases and deaths.
Can you explain the concept of incidental gallbladder cancer and the implication on our patients?
So incidental gallbladder cancers are usually a surprise finding on pathology after a laparoscopic cholecystectomy for presumed biliary colic and gallstones. And we do watch out for it, and I guess that's why every single gallbladder that's removed is sent to the lab and analysed under the microscope to look for dysplasias and cancers. The incidence is, in Australia, certainly been less than the global incidence of 1%. I don't think we come across that many. And when we do, it is people who have had, say, a Miritzi syndrome or a large stone impacted in the gallbladder for the longest time, that we have a difficult operation. There aren't any striking features preoperatively on imaging, but there could be a wall thickening, in particular if they have the polyp and they also have a focal wall thickening adjacent to the polyp of more than 4 millimetre, or the polyps have suddenly increased in size by more than 4 millimetres. It makes us a little bit wanting to sort of exclude gallbladder cancer and think about it. But it's mostly relying on the ultrasound finding or the CT finding of a gallbladder wall thickening or abnormal septations in the gallbladder wall, or it's sort of looking like it's infiltrating into the adjacent liver. and I think they would warrant further characterisation with an MRI before proceeding to surgery, and a referral perhaps to a hepatobiliary surgeon rather than having it done routinely on a public general surgical list, because we would treat it slightly differently intraoperatively and do a radical cholecystectomy, which may include a wedge of liver or perhaps a cystic duct lymph node.
Harsheet, should all patients with gallbladder polyps be referred to a surgeon?
Oh, I don't think so. I think the RACGP guidelines correctly say that polyps under 5 millimetres would not warrant any further investigations or referrals. And I think that's important to keep in mind, because patients get quite anxious about it. Even if you're asking them to get interval scans or surveillance scanning, it's provoking anxiety, and they're waiting to get those scans every 6 months or 12 months. So under 5 millimetres, we'd be quite happy to say do nothing. Over a centimetre, absolutely refer to surgeon. And it is that 5 millimetre to 1 centimetre mark which is a bit vague and needs ongoing surveillance. And I think that's where it's key to then look into whether they're sessile polyps, multiple, single, and reassure patients that if they are multiple polyps under a centimetre, not much needs to be done about it. Now, some patients will need to see a specialist just to be reassured, and that's fair enough. But I think the messaging to the patient needs to be, you probably don't need an operation. I certainly see people in my practice who have been convinced that they need an operation, and they come and tell me themselves that they've Googled it, and Google tells them they don't really need an operation, but they've been rung by a hospital and told they must have an operation.
Do you love it when people Google?
Just sometimes it can be sometimes it can be quite good because they're coming in informed.
Yes.
But on the other hand, there's a lot of myths again that need to be busted.
Just on the guidelines, you mentioned them. Have there been any recent updates to Australian or international guidelines that GPs need to be aware of?
So there are no surgical or hepatobiliary guidelines available, and then the consensus guidelines for radiologists goes back to 2022, so not that recent, but the guidelines can be accessed. It's an open access paper via Google, so it's just the European consensus guidelines on management of gallbladder polyps.
Do the European consensus guidelines cover how often those patients who need surveillance need to be ultrasounded?
That's another pet peeve of mine. So you have to keep in mind that this is a radiology-driven conference and consensus guidelines. They do say 6 to 12 months for the 5 millimetres to 1 centimetre mark, or if you're surveying after the 1 centimetre. And I think we've got to use some judgment there. If we are just following up someone with a 5 millimetre polyp, perhaps a 1 year interval's enough. But if it's bigger, more around the 8 or 9 millimetre mark, then perhaps 6 months.
For those with asymptomatic cases, what's the role between watchful waiting versus really proactive management?
And that's actually a really good point, Julian, because if they have symptoms of biliary colic, perhaps they should be referred to surgeons, because often the difference between a polyp and a stone is whether they're causing shadowing on the ultrasound or not. So there can be a little bit of misinterpretation of stones as polyps. So if they've got symptoms of biliary colic, they should get an operation. If they are truly asymptomatic, then watchful observation is absolutely acceptable with 6 to 12 monthly scans.
What about research in that area?
So the research is for the asymptomatic polyps, and most of them are asymptomatic. So we wouldn't worry too much about it, and the transformation into malignancy is 0.5%.
Let's go back to gallstones and how weight loss is a risk factor for the development of gallstones. Are you seeing a rise in gallstones given, the newer weight loss agents?
Well, I'm certainly seeing more patients on the GLP-1s being referred for gallstones, and there is certainly an association. And we did see an association even after bariatric surgery was first introduced with gallstones. There was a time, certainly when bariatric surgery was being done open, that people would get their gallbladder prophylactically removed because they were expecting them to go on to develop symptomatic gallstones. We don't have much of a registry or proof of why we're doing that in Australia, but the Scandinavian countries are very good at this, and they do have a population-based registry where they've got everyone with bariatric surgery on that registry, and they figured out that it was only 50% of the patients who had bariatric surgery and significant weight loss went on to develop gallstones, and only half of them were symptomatic gallstones. So there's no role for prophylactic cholecystectomies with weight loss surgery or weight loss drugs. We do know there's an association between GLP-1 drugs and pancreatitis. I don't know if there is a clear link from the mechanism of the drug and gallstones, but we're certainly seeing more, and it might have to do with the weight loss that the patients are experiencing. So certainly a lot more patients in my practice are on GLP-1 when they're coming to have their gallbladders removed.
I've seen a few patients who've had babies and they develop gallstones and colic and then they have surgery. It just seems really unfair that you have a new baby and then you have to have surgery. What's the incidence of gallstones and biliary colic in that postnatal period?
Again, it's like I'm obviously biased because I only see the people referred to me, and there's a whole population of people who've had babies and not had much wrong with them, but it's not insignificant. So we do see, and yeah, sometimes there's poor ladies who've had a cesarean section and they're getting repeated biliary colics or obstructive jaundice even, and they've had to have an emergency gallbladder surgery as well. And I do wonder if it is the fluctuation in weight that causes the gallstones to play up at that stage as well.
A 2024 publication titled Non-Surgical Management of Gallstones During Pregnancy, a Clinical Case Report, found that approximately 5% of pregnant women develop gallbladder sludge or gallstones, with 1.2% experiencing biliary pain. It noted that most cases were asymptomatic and managed with diet and monitoring, but untreated symptoms can lead to serious complications like obstruction or pancreatitis.
There's a lot of research obviously ongoing. Is there anything that has interested you or an area that you think will be of great interest to GPs coming down the track?
So I think there is a lot of interest in gallbladder cancer because it's an untapped potential. We haven't made much progress in decades in the outcomes from gallbladder cancer, both early detection as well as chemotherapy. There have been trials in Japan and Southeast Asia on using chemotherapy in the neoadjuvant setting as well as adjuvant setting for gallbladder cancers. And so we're looking for the results of those and seeing where we get at, but also with investigations, and perhaps AI can come in and help us find those patients who are at a higher risk of gallbladder cancer, and early detection is the aim.
I know you've been visiting GP clinics and talking to a lot of GPs. What questions are you getting asked? What interests them?
I think the reason that prompted me to do the podcast or these talk was I used to be asked about gallbladder polyps everywhere I went because there is no consistent practice amongst my colleagues as well, and they were getting mixed messages where some patients were getting operations for their gallbladders or even adenomyomatosis, which is completely benign condition and needs nothing doing, and it was causing a lot of confusion in their minds onto whether this needed intervention or not. So gallbladder polyps has certainly been something that's interested everyone, and we keep getting asked about what should we do about these, and then how often do we follow them up, and when do we refer them to you?
You mentioned right at the start about myths and a bit of myth busting. It's your opportunity. Is there anything now that you want to deal with? Anything else you want to add to that list?
Well, there's a lot of myths around what patients need to do and lifestyle and dietary adjustments after laparoscopic cholecystectomy, and so much so that patients are afraid to have what can be a relatively straightforward and safe operation, mind you, in the right hands, because they can get complications. The commonest things we see after a laparoscopic cholecystectomy are some patients do develop diarrhea or loose stones, especially after they've had a fatty meal, and they could just lay off the fatty meal for a few months and reintroduce it slowly in a trial and error fashion. But there's absolutely no need for them to be on a lifelong fat-restricted diet. And the whole point of the operation is that they can go back to leading a normal, happy lifestyle and making the choices they want to. The other myth I've often sort of seen is around that ongoing pain and symptoms where most of the times they just get, relegated to you're crazy or this is not real. But there is a real post-cholecystectomy syndrome that we need to be thinking about when patients present with pain after. Often we do see blips in LFTs or dilated bile ducts to support the diagnosis of perhaps a sphincter of body dysfunction or a post-cholecystectomy pain. In the initial phases, it's very important to rule out a retained stone in the bile duct, so maybe the cholecystectomy was actually a subtotal cholecystectomy and they're getting recurrent attacks from the left behind stone in the gallbladder itself. So I think it's important to sort of investigate that post-cholecystectomy syndrome as well, and exclude sphincter of body dysfunction if patients continue to get pain after their gallbladder surgeries.
We all have patients on waiting lists waiting to have gallbladder surgery. If they have an episode of biliary colic, what's the best treatment options for their pain relief?
So we'd like to avoid morphine, but the neuroderivatives of opiates such as tapentadol and tramadol do seem to work well, and we can trial that. But I think long story short, if they're getting recurrent attacks of biliary colic that are escalating, they just need to get to surgery quickly. So perhaps an expedited referral or presenting to ED as the worst case scenario.
And is there, if you have someone with cholecystitis, so inflammation and gallstones, can the surgery be done immediately or do they have to wait a certain amount of time before the surgery?
I'd love to do it immediately. It's actually the safest and the easiest for us to do in the first 48 hours of presentation. The question is how long after presentation can you do it? So a lot of my colleagues have an arbitrary mark of 1 week. There's no real evidence to that. It's certainly easier in the first week when there aren't dense fibrinous adhesions developed to the gallbladder and it's not walled off and formed a phlegmon. But there are Japanese guidelines on that suggest that leaving it even 2 weeks from the initial onset is perfectly safe for a emergency laparoscopic cholecystectomy, and that's certainly what I adopt in my practice.
Harsheet, thank you so much for coming in and sharing your expertise with us today. We really appreciate you being on sMater. Before you go, though, we have a little segment called The Checkup. So this is 5 quick questions to give us an idea about you as a person as well as a medical profession. It's supposed to be 5 fast questions. Are you ready for this?
Let's try it.
Over to you, Maria.
What's your superstition?
My superstition? Gosh, I grew up in India. I should have a whole list of superstitions, but I've pretty much spent my life fighting it.
How would you describe your handwriting?
I'm proud of my handwriting. I belong to the days where my mother stood next to me with a copywriting book. So it's actually quite beautiful and neat.
You must be in the minority.
Absolutely.
If a genie could grant you one wish, what would it be?
The wish to be invisible for 24 hours. That would be
that
really
is a good one, yes.
Who do you admire?
I admire all of you. I admire working women who are getting out in this world and achieving their dreams and raising families.
If you weren't doing this, what would you be doing?
To be honest, I have thought about this and I think I'd always be a surgeon in any life.
Thankfully you are, Harsheet. Thanks again for joining us on sMater.
Thank you very much.
For our listeners at home or in the car having a well-deserved break between patients, thanks for tuning in.
See you next time on sMater.